Hi, everyone. I'm Leslyn Keith with the Lipedema Project and Lipedema Simplified. And I get together with you each the first and third Thursday to give you some research updates. I review papers that have relevance to lipedema. And so I have a really good paper I'm going to talk to you about today. Also have a couple of announcements of events and happenings that are coming up. So I'll talk to you about that at the end. But let me talk to you about this really interesting paper. It came out in January of 2022, and it's called Prevalence of Clinical Manifestations and Orthopedic Alterations in Patients with Lipedema, a Prospective Cohort Study. And this paper was written by Dr. Isabel Forner Cordero out of Spain. And so she and her colleagues did this study in the clinic that she works at. And I wanted to share that with you today because I think it has some interesting implications and it might really apply to you or someone you know. So the purpose of this paper was, or the study was, to describe the clinical manifestations of lipedema that they were seeing in their clinic in Spain. But they also wanted to look at what is the incidence, what's the prevalence of orthopedic changes associated with lipedema. And I think that there's several findings in this study that are really interesting. So it was a prospective study, meaning that they were looking at they were asking women if they wanted to participate, and then they would look at all their chart information. So it was women that were seen in the clinic between 2012 and 2019. And so a total of 138 women were accepted into the study. So what were the inclusion criteria? What allowed them to participate? They had to be at least 18 years old. They had to have both legs involved. So both legs were enlarged. And then they had to show at least 3 symptoms of lipedema. And so that would include spontaneous or provoked pain or tenderness, easy bruising, a family history of lipedema, and a negative stemmer sign, as well as that disproportionate deposition of fat to the lower body. So, and they had several other clinical manifestations of lipedema that they listed. So you had to have at least 3 and have your legs involved, and you had to be an adult in order to participate. But the things that excluded you from participating were pregnancy, if you had kidney, liver, or heart failure, if you had a DVT or a deep vein thrombosis, a blood clot, if you had an infection, or if you had active cancer. So that excluded you from the study. So what's the data that they collected? They collected a lot. This was really good. So they got all the basic demographic data, your height, your weight, where you lived, all that kind of stuff. Plus the clinical characteristics. They took data on all those clinical characteristics of lipedema that you were exhibiting. So they looked at those things we talked about, the disproportionate fat, the pain, the bruising, stuff like that. They measured the legs, so they did calculate the volume of the legs. They did a lot of extra stuff on pain. What type of pain was it? What frequency? What was the intensity? So a lot on pain. They also documented what type of lipedema you had. So remember, there's those 5 types, and it really describes where the lipedema fat was on your body. And then they also put what stage of lipedema you were, so stage 1 through 4. And then they took documentation on vascular changes, stuff, what was happening to your veins. Did you have chronic venous insufficiency, varicose veins, spider veins? They took information on all of this. Then they also did, what was the impact of lipedema on your daily life? And then, of course, then they also looked at those orthopedic manifestations. So did the participant have a really high arch or a flat foot? Was there knee misalignment? So the 2 types they were looking for was varus, which varus knee means you're bow-legged, or valgus knee means that you are knock-kneed. And then they also were looking for osteoarthritis in the knees. And so what did they get? So they got 138 women that were in the study, and the average age was 47. The average BMI was 30, and actually it was just below 29.9. So that means that's just below the marker for obesity. But that means since that was an average, they had several that did have that were obese. So 23% had a normal BMI, 31 were overweight, and 38% were obese, and 8% were morbidly obese. That means a BMI of over 40. But the researchers and all of us know that BMI is not such a good measure of what's going on with a woman with lipedema. So they also did what's called the waist to height ratio. And so it really, that could show that if we have, when you look at the weight according, and also the waist to height, then we can tell, oh, the weight is all on the lower body, which would be typical with lipedema. And so when we looked at the ratio and the way that it's divided by normal weight, overweight, and obesity, in this way, we had 41% instead of just 23% were normal, were called slim or healthy. And 20% instead of 31% were considered overweight, and 36% were obese or morbidly obese, whereas that was 46% for obese and morbidly obese when we use BMI. So you can see how you get a little different perspective when you're using that waist to height measure. And then the most frequent type of lipedema was type 3, and that's, remember, the fat deposition that goes from the waist to the ankles. So that was 98 out of the 138 women, or 71%, were type 3. And then the stage, most of them were in stage 1 or 2. Actually, 100 of the 138 women were stage 1 or 2, so 73%. So this really looked at mostly early stage women, but we definitely had another 38 that were in the higher stages. And then this I found very interesting. The average time from onset of the symptoms until they got an official diagnosis was 25 years. Absolutely amazing, because when you think that's an average, some took longer than 25 years to get a diagnosis. That is, I thought, astounding. And then most of the participants, the onset was at puberty. And so you think around 15, and so you're waiting until you're 40 to actually get a diagnosis. That's pretty astounding. And then let's see, interestingly, the more advanced stage, so if you were a higher, more severe stage of lipedema, and if you had a higher BMI, or if you had a higher waist to height ratio, and you tend to have more pain, and this all was correlated with age. So that they all tracked together. Things got more severe as you got older. And then 92% of participants reported pain. So that was a lot to be experiencing pain. 100% had both legs involved, and that was one of the criteria to be included in the study. So that makes sense. And then 86% had that feature of being disproportionate between the lower body and the upper body. 90% bruised frequently. That's interesting, because sometimes that bruising is not talked about a whole lot. It's a symptom or a characteristic we tend to gloss over, but that is a very, very common characteristic. And actually 90% had spider veins, so the beginning of venous problems. But now let's look at the orthopedic changes. So 30% actually had a high arch. That is very interesting, because as your weight increases and the pressure on your feet increases, a lot of times that arch is going to fall. And only 15% had flat feet where that arch had fallen. And then as far as being bow-legged or having varus knee, just 5 out of the 138 participants, or less than 40%, 4% had the varus knee, but the valgus knee was much more prevalent. And this is a condition that is often associated with obesity, just the weight of the person, and also the increased fat at the medial thigh tends to push the legs out. And so that impaired stance and gait makes that knee be not lined up. And so this is a very common condition you can get when you have that heavier weight and that deposition of that fat. So 39% of the participants had that valgus knee or a knock-kneed deformity. Knee pain, this was interesting. 87 out of 138 participants complained of knee pain, varying in intensity, but average was rated at 6 out of 10, 10 being the worst pain. And that makes sense that 63% would have this knee pain because it's very often associated with having increased weight. Osteoarthritis, had 13% had osteoarthritis, and definitely the osteoarthritis in the knee was more severe in the older participants and those with the higher BMI and a later stage of lipedema. So all those things seem to track really well. So before I tell you some of the conclusions that they came up with the study, first I want to tell you about some of the limitations. Every study is going to have, no matter how well done, you're going to have some limitations. And this one was mostly in selection bias, because this is what happened. Most of the participants were type 3 and stage 1 or 2. So we really had a select population of lipedema. And it may be because that what the author said is that because this is when you're stage 1 or 2 and you present with the type of lipedema, waist to ankles, type 3, sometimes it's much easier to distinguish from simple obesity. And so it might have been this specific presentation of lipedema ended up being recruited because it was easiest to differentiate and make sure, okay, we don't have obesity, we definitely have lipedema here. So it really narrowed the group that we were looking at. And so for that reason, the authors say that maybe this doesn't really reflect the entire population of people with lipedema in Spain, but it was still very demonstrative. And then only 63 out of the 138 participants actually had imaging to see if they had osteoarthritis. So this was a very small portion. It looks like less than half of the participants actually had that imaging. So the osteoarthritis could be more prevalent, but it still was a large amount that they found out that they did have osteoarthritis. So, and also the type of imaging they used, X-ray, can't show what's happening to the cartilage. So you could have had cartilage damage and actually osteoarthritis. And in those people that they did image with the X-ray, they might have missed some people. So they're not, what they think is that it might actually be more prevalent than what they found. So let's look at their conclusions. So they definitely saw osteoarthritis more severe in the older participants and those with the higher BMI and a later stage of lipedema. So the more advanced the stage, the higher BMI, the greater the waist to hip ratio, waist to height ratio, and increased pain all tracked with age. So that all got worse with age. And the author said that this may be further substantiation that lipedema is a progressive disease because it was much more worse and the longer they had it and with age. And then in other studies, they had shown a pretty high frequency of having obesity with lipedema. When they used BMI, in this study, just 46% were obese. But other studies had shown 76 to 88% being obese with using BMI. And then using a waist to height ratio, in this study, only 36% were obese. So they showed a much lower incidence of obesity associated with lipedema. And then, as I already pointed out before, the length of time to get a diagnosis, average of 25 years, was just astounding. And the authors say that we really have to do good work to increase the awareness among healthcare providers, because this is, you're getting a population that's much more severe, much more advanced before you're trying to do good interventions, and they're not going to work as well. And they'll, so getting people earlier, diagnosing in a more timely fashion and getting them the proper treatment is really important. Pain was, in almost all participants was there, and it impacted their work or social activities in 38% of the participants. And so the authors say that the management of lipedema pain really needs to be a focus of our intervention efforts. Do what we can to do better on that. And then the frequency of knee pain and orthopedic alterations demonstrates a significant impact in lipedema, and it can really have an impact a person's ability to exercise, or it can just impact your general mobility. So they feel like this is something that really needs to be addressed. And they did point out, in the general population of Spain, there is about 15% of the people in Spain have osteoarthritis. In this study, of the ones that were imaged, so 37 out of the 63 patients that were imaged had osteoarthritis. That's 58%. And so that it may be that we have more osteoarthritis in the knees in lipedema. So the authors are really urged that this is part of a standard evaluation for lipedema. We really need to see what's going on with the knees and other joints as well, but specifically that this seems to be a big problem with knees and lipedema. So let's make sure that we look at that when we're evaluating a person with lipedema. I have a link posted for the abstract of this paper. I think I actually contacted Dr. Fornero Cordero to get the full text of the article. So if you want to read the full text, email me. If you want more than just that abstract, email me. I'm at leslyn@lipedemaproject.org, and I'll send you the article. And as always, if you have any other papers that you want me to review, and I have a stack of papers all set to go. So let me know if you have any that you would like me to review. You can email me, you can post it here. And I'm just looking really quick at some of the things that you all have posted. Yes, hi, Julie, who's my neighbor in Camarillo. She's right, only about 20 minutes away from me here in California. And Zelda's from Nova Scotia. Hello. Vicky is here. You didn't say it's your first time, but you didn't say where you are. I'd love to know where you are in the world. Cindy's here from Canada. I think I recognize your name, Cindy, from our event we just had last weekend. Jean is here from California. And let's see. Yes, and someone, Restoration House Ministries and International, I'm wondering if that's Nobuchle. You have to remember that BMI is not a good reflection of what's happening with lipedema. Better to use the waist to height ratio. And let's see, Melina says, where can you receive the info on that waist to height ratio? If you just Google that, Melina, it tells you all about it. And we're seeing it more and more papers with lipedema. They might give the BMI information, but they also are doing waist to height because it is just a better reflection for lipedema. Yes, Barb talks about there's calculators online that it can calculate your waist to height ratio for you. We're really looking for it to be below 1. That is what's considered healthy. If it's above 1, then it says that can show that you might have some abdominal obesity, which means now you're not as metabolically healthy. Thank you for posting that, Barb. And then very interesting about the high foot arch. She wanted to have the link to the study, which we've now given. I was kind of surprised about that too. And Francine, so disheartening for us older population with lipedema. Yes, it definitely can get harder for you, but we are finding interventions do help at any age. So don't give up hope. People are doing better. Let's see, another person posted, I'm going to the doctor today to get officially diagnosed. Of course, I had to educate the doctor, and so he could do some research, and he's going to take pictures of my legs. Wow, sounds like you've got a good doctor. And that's what we're doing. We're educating one at a time. And the doctors that are open to that is we want to work with those people. That's great. Juanetta had light wave therapy on her knees yesterday, and that let us know how that goes. That sounds great. I hope that really helps. Oh, we got someone here from New Zealand, someone from Iowa, Louisiana, another person from California. Oh, and Melina says she's in Texas. Great. Oh, and the Restoration House Ministries, that's Eugenia from Bermuda, which I think that you were at our event last weekend too. I recognize your name. And Stephanie from Oklahoma City. Okay. Wow. You guys are just posting like crazy. Thank you so much. I have to wrap up here. Ruth from Phoenix and Kathy just saw a vascular surgeon yesterday. Yes. That is someone that you may need on your team as a vascular surgeon. Good. I want to give you a couple of announcements before I finish today. For those of you that are interested in joining the tribe, the membership is open until Monday, April 10th. So you have until then to join. And it's only open typically once a year, but we do open it up for a very short time at other special times like now. We just had our event last weekend. So be sure and follow that link that's posted below to find out more information and join the tribe. We'd love to have you. And then one of the activities that we do that you get a discount for if you're in tribe, but it's open to everybody, is a special coaching special interest group. And it's Living Well with Lipedema. That's going to be on Mondays starting April 17. We're going to have lots of guest speakers, including myself and other people at Lipedema Simplified. And this is a thing that our coaches run. So you will find out more about our coaches and the special things that they can help you with. So also follow the link to find out more about that group starting on April 17 on Mondays. And that's all I have for you today. It was wonderful being with you again today. Thank you for everybody who posted. And I'll be back again, remember, the first and third Thursday with all these research updates. See you all next